Hello, I'm Tom Babor, and I'd like to introduce you to Katy Carroll, who was trained as a clinical psychologist at the University of Minnesota, and since that time has been a prototypical addiction scientist doing clinical research over the course of almost 30 years as a member of the substance abuse treatment unit at Yale University. So, Katy, I'd like to ask you a few questions about your career and where you think the field of clinical research in addiction science is going. You got your degree in clinical psychology, and soon after that, you went to work as a researcher doing psychotherapy research at Yale. What engaged you at such an early stage in your career in doing clinical research on the treatment of addiction?
It was, and to some extent remains, pretty wide open. Lots of room for improvement. When I started, I was the first substance abuse intern in the training program at Yale. So there never had been one before. And it was a wonderful time because there was Herb Kleber and Bruce Rounsaville and Tom Costin and there was openness to ideas. It was a great area because there was expertise in so many different areas, pharmacotherapy and so forth. And I realized early on, treatment had to be a little bit better than just going into a room with a clinician and having somebody send them to AA meetings. Not that there's anything wrong with AA, but when I began, there were no manuals, there were no standards, there were no evidence-based therapies, and the world has changed a little bit, and it's nice to see, although there's plenty more to do.
So when you got out of graduate school, trained as a psychologist, you had some choices. You could have gone into clinical research. You could have got just a clinical practice. You could have gotten a job as a university assistant professor. But you went into research. And have you ever regretted it? And what would have been the advantages of spending the majority of your time doing research as opposed to clinical practice or other things?
What's nice about research and what's incredibly exciting and why I feel like I'm one of the luckiest people in the world is, although it's hard and writing grants and having new ideas and going through the review process is tough and arduous and you don't know what's going to happen. But if you're lucky, like you and I and our colleagues have been, you get to do exactly the kind of work that you want to do and carry forward ideas and train new people and hopefully have some influence on both clinical practice and research. So it's actually turned out far better than I ever thought, but it was also a matter of kind of knowing what I wanted to do, but then taking advantage of things along the way. Like right out of getting my PhD, we started working in Project Match, and that was just being in the right place at the right time with the right colleagues. So, yeah.
You mentioned working with people like Bruce Rounsaville and Herb Kleber. What is the value of working at a specialized research center as opposed to doing research within, let's say, an academic department like a department of psychology, or doing research within a treatment program where conceivably you may have fewer resources?
There are a variety of really great places like that, like Yale and UConn and a variety throughout the U.S., UPenn and so forth. And what's nice about a department like that is there's mentorship, which I think is just having good and generous mentors is really what makes it happen for most people, I think, and or good training programs. There's also some guidance about developing pilot work and some support for pilot research, which I think is just essential to young people getting started. Clinical trials research is it's incredibly complex. You can't do it by yourself. It really takes a variety of people who know the regulatory part, the training part, the statistics and the outcome part, and outside of a team like that, I think it's not impossible, but it's more challenging. And our department has been nice because we are in an academic psychiatry thing, so it's a really clinical department. So we actually do clinical trials in community-based and research-based clinics with patients who come in with all kinds of complicated problems. So it keeps the work at a very challenging but exciting level.
Yeah.
Yeah.
When you got started as a graduate student, you had a pre-doctoral fellowship from the American Association of University Women.
Yes.
And that implies that somebody was investing in graduate education in women.
Right.
And what I want to ask you is, what has been the role of women in addiction research since you got into the field, and have the opportunities increased? Have things changed in any way? And are gender issues important in addiction research?
That's a complicated question, but when I began, it was who was at Yale? It was her. Notice the names here: her, Bruce, Tom, Richard, and I was Stephanie and O'Malley and I were the only women. At the tenured faculty meeting, it was all men when I began. And now within our department, I think we have 10 tenured people within 10 or 11 tenured faculty within the Division of Substance Use in Psychiatry, which is impressive because it's a large department, the majority of whom are women. So I think it was challenging in the beginning, but not insurmountable. I think the acceptance of women scientists in substance use has been maybe a little easier than in a lot of other fields. So I never really felt like it was much of a hindrance. Mm-hmm. But it's better and better for women in CPDD now. There's a particular category of award named for Marion Fishman, who was just an outstanding female scientist. And NIDA is run by Nora Volkov, who's a nostalgia. Yeah, so it's changed a lot. There's lots of opportunities.
So speaking of opportunities, when you think about the growth of psychotherapy research in particular, and in more general terms, the developments in research on addiction treatment, there are questions that appear to be culturally specific.
Right.
And the United States has been a big engine for this kind of research. What are the opportunities for people doing this kind of research in other parts of the world? Asia, for example, or Africa, or Latin America, where the concepts and the approaches could be expanded to include a variety of different types of interventions that are culturally appropriate for a particular region or country, but would not necessarily work well in the United States.
Yeah, no, I think it's wonderful, and you've done a lot of work with the World Health Organization, and I've been part of the United Nations strategies for developing what treatment research. First, recognizing that not everybody has to start out from zero. I think that's really important. We've come a long way in this country from moving away from punitive approaches, which, if you think about substance use in a vacuum and how vulnerable our patients are, a lot of the first ideas well-meaning people have are a little punitive and harmful, and we've moved past that, and hopefully everybody's moving past that. But I think there's a couple principles that work relatively broadly across all kinds of substance abuse problems, but it really is essential that it be done in a culturally appropriate way. So we worked with somebody who took CBT and translated it into Swahili. And instead of talking about Pavlov and the dogs, they talked about chickens, and it worked. And I think now it's a wonderful thing. One of the projects we just finished was a cultural adaptation of CBT, or computerized CBT, into Spanish, which really meant thinking through not just a translation into Spanish, but thinking through the culture, the values, and teaching CBT, but using language and concepts and characters in the movies that would resonate. So instead of a narrator, some white guy saying do this, we actually the priest comes to the family and do it, and the narrator for the thing is the wise abuela watching this telenovela. So there's fun and opportunities, and all of a sudden we have a nice standardized effective approach that can be used with, I think, all kinds of Spanish-speaking populations. So there's a lot of work now on, sort of developing CBT in different countries and cultures. And I think a lot of great ideas have come from Europe and Africa and Asia, coming this way too, which is exciting.
So in the course of your career, you've worked on some major psychotherapy projects, Project Match, the Marijuana Treatment Project. You've been working with a pioneering group to develop manual guided therapies. In 25 words or less, what have you learned during your career, and what impact has this had on the way people think about treatment in the resolution of problems connected with substance abuse?
I think we've come a long way, but there's a lot more to go. I can't necessarily say that overall treatment is better in the United States than when I started. Because for all kinds of reasons, but partly it's that there's currently no emphasis on outcome, as there is in so many other fields, and because if no one is charged with demonstrating that people have a certain outcome, that you can come into this program and on average you're going to reduce your substance use or this much, the field is still unregulated, and so there's really no incentives to adopt treatment that work. Sadly, and you might have to cut this out, the insurance companies continues to pay for stupid stuff that either has been proven not to work or cause harm, like detox without follow-up, all kind, or sort of unstructured group therapies. So we still, and billions goes into that, and so little goes into actually empirically validated the therapies. And so my emphasis now is just trying to figure out how you get people to stop doing stupid stuff and start doing the stuff that.
But does that mean we've made a lot of progress in understanding what changes people's alcohol and drug use behavior, but we haven't been able to translate that into routine clinical practice?
I can't say we completely understand, but there are several principles that I think are broadly applicable and have shown to work. It's a relapsing disorder. You have to think about it as a public health problem. Your work with SBIRT interventions, a little well-timed work can go a long way in changing people. I still think we have a long way to go in trying to think about, cognitive targets and sort of what do you have to change to produce lasting change? But we're a lot better than when we started out.
Okay, well, thanks very much for doing the interview.
That was great, and thanks for all your work. It's been great.
Okay.